Good morning, and Mr. Chairperson, thank you for inviting me to talk. And I will be talking to you today first on management of Group 3 and 4. Still counting down here the last polling question. So, during my last visit in China for a speaker tour, I entered the hotel lobby in Shanghai and I was surprised to see a group of tourists, Chinese women, with saying POSEIDON Group on the sweatshirt, as you can see in the picture. So I approached them and started to talk to them. And I told them that I'm also a founding member of the POSEIDON Group, which has something to do with reproductive medicine. So they became very excited and asked me a few questions. For example, what is my chance to have a baby in the future? And I said, well, good news and bad news. If you are old, you might have a problem and have a low probability of having a live birth. But if you are young, with the same number of eggs that you will retrieve, you will have a better chance. After that, I went to visit one of the centers, and I told them about this experience with the young ladies. So they asked me, okay, why is it like that? And what can we do about it? So the first problem, and I already mentioned it in my first lecture yesterday in the morning, is the euploidity of the oocyte, which is an age-dependent situation. And here again from my center data to show that euploidity drops after the age of 35, and at the age of 40, 41, it's only about 10 to 50% probability to find a euploid egg. So the same if you look at the blastocyst publication from the US, you see exactly the same situation in the blastocyst euploidity rate if you can reach the blastocyst. And you need a lot of oocytes and a lot of blastocysts in order to correct the situation and to find a euploid embryo. But also the number is important, and you can see that the significance of just one more oocyte, especially in the group where you have low numbers of oocytes, how important the increase might be in the probability to have a pregnancy or a live birth age. And that's true in any age of the patient. So they asked me, what can we do about it? How do we manage this? And I said, that's difficult. So we have to look what kind of pituitary suppression in our regime treatment we do. What shall we use for the stimulation? What kind of gonadotropins? What kind of dose? Is natural cycle a good situation? Shall we use multiple stimulations, double stimulations? Can we use adjuvants like androgens or LH, growth hormone, or just accumulate? So we have many options that we can look, and now we should analyze all these options and see what is really helpful and what is not helpful. So first of all, let's start with the agonist analog regime. And this is the latest meta-analysis by Lambach in the Cochrane database. And there you can see that there is no difference in the poor responder group that was looked at this analysis if you use long agonist or antagonist protocol. So no significant difference whatever you choose to use. What about the dose of the FSH? Well, it showed that you will significantly have higher probability of achieving more oocytes if you use a dose higher than 150. But there is no difference if you go above 300 units. So if you give 450, 600, there will be no difference in the outcome of the numbers of the oocyte. The probability of having a cancellation will be higher if you are less than 300 units, but again, no difference if you go above 300 units, or 450, 600 is not recommended. What about live birth or ongoing pregnancy rate? Well, the samples, as you can see here, are very small, so it's very difficult to conclude any conclusions from this, because there is no power enough to say something about live birth rate comparing the different doses of the gonadotropin used for the stimulation. So what about using a natural cycle? And here you can see one of the latest studies by Polizos looking at the outcome of using natural cycle. And you can see that the live birth rate per cycle was very low. So actually, in the conclusion of the summary of the study, they say that it's actually not recommended and it's not a good solution for this subgroup of patients. Dual stimulation. Filippo told us quite a lot yesterday. And yes, this is a tool that we can use to increase the number of oocyte and possibly blastocysts, and especially euploid blastocyst, in a shorter time of stimulation and reduce the time to pregnancy or to live birth just by continuing stimulating either in double, or now some people also do triple stimulation, and to try to increase the number of the oocyte, which is important by doing this kind of stimulation. Now let's look at androgen supplementation. Now, in order to understand the possibility of androgens to help us, we have to know that androgens are important in 2 points. The initial recruitment, which is important at this point, and this is about 3 months, 2 to 3 months before you see your follicle in the menstrual cycle. By reducing the atresia of the starting growing follicles, you might increase the number of follicles that continue to grow from the pool. And the second action of androgens, as Carlo mentioned already before, is at this point by increasing the sensitivity of the granulosa cells to the FSH. By increasing the sensitivity of the receptor for the FSH, you might have more follicles at the beginning of the cycle started growing. So this is the cyclic recruitment that testosterone or androgen can be of help. Now, the most used products are either DHEA or testosterone, and they are different in terms of the affinity to the receptor, but also in terms of increasing intrafollicular testosterone level and the level of testosterone and androgen receptor expression, as you can see from this side. So it's a huge difference between the two of them. And the latest meta-analysis just published last year, you can see looking at DHEA, there is no difference in the number of the oocytes, number of metaphase 2, clinical pregnancy rate, or live birth rate. So the conclusion about using DHEA, that there is no scientific evidence at the moment for clinical relevant benefit. DHEA is a very weak androgen, as you have seen before. The advantage is, of course, that it has low cost and the side effects are very minimal if you use it. So the conclusion will be we might need more trials and more RCTs to try to find out if it is really helpful on the long. What about using testosterone? Well, the same meta-analysis looked again. And what you can see, there was a benefit in the number of oocytes, metaphase 2, clinical pregnancy, and live birth rate. So you say, oh, we have now the magic bullet to help us in the poor viral response. But you have to be a caution, because if you look, sorry for that, if you look, the numbers are very small. So taking conclusions with these very small numbers is a problem. Also, if you analyze the studies included, they were using different dosage of testosterone, starting at different points before and using it for different long time, and also using different testosterone products. So it's not a very homogeneous group of studies that we can rely on. So again, there is no enough scientific evidence that we can use testosterone. It's also a question how long we should use it, what should be the dose that we should use, and which will be the patient that will be really profiting from using the testosterone. Now, fortunately enough, Nikos Politos started a very large and very good study called the T-Transport study, which is still ongoing. It's not finished yet because they recruit 450 poor responder patients and they do it in 4 different centers in different parts in the world. And they start with the same dose in all the centers, and they use it at least starting 2 months before starting the stimulation. So as you can imagine, it's not easy to recruit the patients, so it's still going on, and we still need to wait for the result of this very good and powered study to see if testosterone is of help. Another situation that you can use is to use priming of the T cells to produce androgens. It's called LH priming, and this can be also a possibility to increase the circular recruitment of the follicles at the beginning of the cycle. And a study has been published some years ago. It repeated the study by Professor Jean-Noël Hug, who did it about 20 years ago. He did it at that time with HCG, and now it was studied with recombinant LH, starting after downregulation with GnRH analog for 4 days with 150 units of recombinant LH, and only after that starting the stimulation with recombinant FSH. And what you can see here is that they could increase, compared to the previous cycle, the number of the oocyte by 1, but more significantly increase the implantation rate, clinical pregnancy rate, live birth rate per patient compared to the previous cycle that they used. So what about growth hormone? It's another supplement that is used now quite extensively in some places in the world. So growth hormone exerts effect through its own receptor on the granulosa cells and stimulation on IGF production in the liver and the ovary. It regulates steroidogenesis, follicular development, and oocyte maturation. And it's increased expression of FSH and LH in granulosa cells. So we can say that growth hormone acts as a co-gonadotrophin within the ovary itself. So here is just published last year a very large 482 low prognosis patients according to the POSEIDON criteria. And they used it in group 1, 2, 3, 4, so all the groups. And they found in this study that in all the 4 groups, the live birth rate and clinical pregnancy rate increased. And this was the only one that actually had this information on the POSEIDON groups. But when I looked at the latest meta-analysis, which just published short after that, it showed that looking at 12 RCTs, including now almost 600 patients, indeed, there were a significant improvement in the number of the oocyte, number of metaphase 2 oocyte, and number of embryos which were available to transfer. But there was no improvement in the live birth rate. So at the moment, that's what they concluded. We cannot say that growth hormone will improve the live birth rate by using as a supplement. Here again, we have the problem and the issue of what is the daily dose for the usage. What is the duration of the use to start with the stimulation, start before the stimulation, how long before the stimulation, and of course the cost effectiveness. It's a very expensive drug to use, and is it really helpful or not? So again, we need more trials. And what about using it in LH now in porovarian studies? Well, in the past, it said that it will increase the number of the oocytes by 1. But when the SPART study was done in Bologna criteria subgroups aligned, using either monotherapy with recombinant FSH or recombinant FSH plus recombinant LH, we found that there was no significant increase in the number of the oocytes. But in the post hoc analysis, it showed that in the severe or the moderate subgroup of the Bologna criteria, there was indeed an increase of the live birth rate and a reduction of the probability to have a pregnancy failure. So the competence of the oocytes increased by using the recombinant LH in this subgroup. And later on, it was also showed in another real-world data analysis that the cumulative live birth rate in these two subgroups was significantly higher when LH was used compared to just monotherapy with recombinant FSH. Which are the subgroups who benefit? Alessandro Conforti and Carlo presented last year this meta-analysis to look at advanced maternal age, because that was the subgroup that was initiated here. And what they found was that if they look at the subgroup between 35 and 39, there was no increase in the number of oocytes or metaphase 2 oocytes, but they could show an increase in implantation rate and increase in pregnancy rate. When they looked at the whole cohort of patients over the age of 35, now including those also over 40, they could not find any significant difference in the implantation and pregnancy rate. So the question is, why is that? Why the older ones will not benefit if they are younger one, but they are all over 35? Well, they do benefit, but you cannot see the benefit in the whole picture, because the patients over 40 have a very high aneuploidity rate. So that will affect negatively the implantation and the pregnancy rate. And because of that, it will dilute the results. So looking now at the whole group, you will not see a benefit. Looking at the group which has less aneuploidity rate, you can demonstrate statistically also the benefit. So when we summarize now, we have group 3 of POSEIDON, and they are younger patients, less than 35, had a low ovarian reserve. So they have a low reserve, but they have a good quality because the euploidity rate is good in this patient. And the reason for the low response is, of course, the low number of the reserved follicles. But of course, it can be asynchronous development, as it was mentioned already in the discussion before. And you cannot forget that they can also have polymorphisms of the FSH-LH molecule or their receptors. So you can take that also in account. And the treatment will be either using long agonist treatment, or you can use antagonist. Especially in that case, you should use either estradiol or progesterones in the luteal phase to avoid asynchrony. And you can use, of course, dual stimulation. You should use 300 units of recombinant FSH. And if you predict that they might have also a problem with polymorphisms, you can add, of course, LH. And you can aim for a fresh transfer because you don't need so many oocytes in these patients. But of course, you can also accumulate or do dual stimulation and transfer later. In group number 4, these are patients with poor ovarian reserve and poor quality of the oocytes because their nucleoticity rate is high. So again, the reason for the low response is the low number of the reserve. Again, asynchronous, and also here, you have to think that you might have polymorphisms. You cannot ignore that. So in this patient, again, you can use long agonist protocols or to help the synchronization or use estradiol or progesterones in the luteal phase to avoid asynchronity. Here, you should use recombinant LH in combination of recombinant FSH. It's still a question mark about the androgens, growth hormone. You should use dual stimulation in order to increase the number of the oocyte and have a higher possibility to have a euploid embryo. You can use the calculator to make a decision how many oocytes you might need. And this will help you to discuss with the patient what will be now the management according to the number of the oocytes you need and what is your point of the starting point, and to prepare them for the journey of a treatment and not just for a single cycle, and to have a more individualized treatment and to shorten the time to pregnancy. And I will skip now all this conclusion because I'm out of my time. So thank you very much, and I'm happy now to continue with the next part.